Hello, everyone. Thanks for joining us on this Conversations in Interferon Gamma Diseases. I am Ashish Kumar from Cincinnati Children's Hospital Medical Center, and I'm very pleased to have my colleagues, Dr. Scott Canna.
Hi. Scott Canna, Children's in Philadelphia.
Great. And Dr. Pui Lee.
I am Pui Lee from Boston Children's Hospital, pediatric rheumatology physician.
Great. Thanks very much for joining me. And in this episode, we will be discussing newer understandings in the pathophysiology and diagnostics of primary HLH and the newer treatment strategies that can be incorporated into this specific group of diseases. And so what do we mean by primary HLH? In very broad terms, it's a genetic disorder that is most likely associated with the development of the state of HLH, which is a state of systemic inflammation. And historically, this was recognized as a term called familial HLH, which was specific to perhaps 5 genes that were all involved in the perforin-mediated granule secretory pathway, which is part of the lymphocytic, cytotoxic lymphocytes, specifically CD8 cells and NK cells. It has expanded to include a few other genetic diseases that all result in the similar outcome of primary HLH, which we all recognize as a condition that is associated with systemic inflammation that can become rapidly life-threatening. Now, more recently, in the last decade or so, it has become apparent that in this group of diseases, primary HLH, whether it is familial or the other ones, these activated NK cells and T cells secrete large amounts of interferon gamma, which then activates macrophages, which then secrete additional cytokines, setting up the cascade of the disease that we recognize as primary HLH or the syndrome of HLH. And so, thinking of primary HLH, we think in general, because it's a genetic disorder, most often it presents in childhood. But sometimes when I say childhood, I mean infancy is the time when we often see it, but we see it in older generations as well, in older children, and very rarely in young adults as well. And I would like to hear from my colleagues, Dr. Canna and Dr. Lee, if you have, what has been your general experience of the epidemiology of primary HLH? Dr. Canna?
Oh, okay. I think it mirrors yours, where most of the patients are presenting within the first year of life. And I think that we anchor on the extremes. And so it's easy to bring to mind the 7-year-old who was previously healthy, who had undetectable perforin levels, or older children. There's been some correlation between the degree of the cytotoxic impairment and a later age of presentation. So, not every UNC13D mutation is equally damaging.
Sure.
And arguably, the ones that are less damaging but still quite damaging might present a little bit later. But I also, and we'll talk about this probably, anchor a bit on some of the really unusual presentations of what ended up being familial HLH that were really just in the CNS of the liver.
In the CNS, right.
And I'll let Pui, probably, Dr. Lee has more experience with those, so I'll defer to him.
Yeah, I think the general experience is similar, where we see a lot of infancy, often triggered in the virus, like viruses during infancy, when they have the right profile of the genetic variants. But we've seen some cases of these hypomorphic variants that makes things very unpredictable. They're the same gene, right? These are variants that perhaps affect function in a less significant way, perhaps waiting for the right sort of second hit, as we will, to bring on the disease. And sometimes they come in really unusual fashions, right? Within the CNS, those are really challenging ones for us to both diagnose and manage.
Yep. So, but getting back to the clinical presentations, and one of the biggest challenges in this disease historically, and even to this day, is making the correct diagnosis. And so, we mentioned this in the first episode of this conversation about the different diagnostic criteria. And at least in the hematology oncology world, people still use the HLH 2004 criteria, which were extremely useful in 20 years ago when they were first initiated. Back then, when the knowledge and understanding of this disease was very limited, but now we have newer diagnostic tools to diagnose specifically not just whether it is primary HLH, but you can even diagnose the underlying genetic deficiency using these rapid and specific flow cytometry based assays. Dr. Khanna mentioned perforin, which was one with the first genetic defect that was identified in primary HLH. And with the flow cytometry, you can readily detect the presence or absence of perforin on cytotoxic T cells and NK cells. And if you see absence of perforin in a child in whom you suspect HLH, then not only have you confirmed that they have primary HLH, you've even diagnosed them as having primary HLH due to perforin deficiency. And then the second test I would mention is the perforin the cytotoxic degranulation assay, which we call CD107A. That measures the function of perhaps all the other genes involved in moving the cytotoxic granules from inside the cell to the immunologic synapse. And the combination of these assays gives a lot more specificity, credibility in making the diagnosis. Now, unfortunately, they're not available at every institution, nor are they included in any of the diagnostic criteria, but these have become sort of the hallmarks or cornerstones of making the diagnosis quickly. But at the same time, with the novel understanding of the utility of interferon gamma, we have newer assays that have also become available, perhaps not as specific as the flow cytometry based assays of perforin and CD107A. And so I would like to ask my colleagues again, and Dr. Lee, I might start with you. When you suspect a child with in your institution with the primary HLH, which diagnostic modalities do you rely on, or have you historically relied on, and what do you do about in that situation?
I think the first thing we think about is the genetics. That certainly is going to take a number of days before results come back. But rapid panels sometimes it comes back within days, and that's really ultimately what will clinch a diagnosis from a really important way and think about the future of the treatment for the patients. But we use a number of other tests to help support the concept of this cytokine storm derangement, with not only specific for HLH alone, but with this whole spectrum of interferon gamma driven diseases. On the second episode, we talked a little bit about CXCL9. We talked about cytokine panels, and IL-18 as another cytokine that could sort of help support the diagnosis, along with some of the flow cytometry tests you've mentioned.
Okay, Dr. Khanna, how about you?
I have almost nothing to add, Dr. Lee and yourselves. I will say that it's often an all of the above, especially in patients that are quite ill. There are always reasons that the specialized test that you're sending meets a delay. Sometimes it's a small child and there are not enough cells to do the functional assay. I will say that the degranulation assay is amazing when it works, but it can be contaminated, especially in particularly ill children. If there's red blood cell contamination, it just is not detectable. And so you're really glad you sent the genetics. But then there are also an increasing number of genetic defects that impair cytotoxicity that may not be on whatever genetics you sent. ROG was just discussed. And so you might want that NKG7 just came out. If you have an abnormal degranulation panel in a patient who looks to all the world like primary HLH and their genetics don't show you anything, it's probably because you haven't found the right gene. The only thing I would add, and actually this is something Dr. Lee has sort of helped pioneer, is we now have flow cytometric tests to look for the effects of different interferons on monocytes. And you can somewhat parse the type 1 versus type 2 interferon, type 2 interferon being gamma, type 1 alpha beta on monocytes. And that's a clinically available test that we, not always in HLH, but in some of the more sort of immune dysregulation patients, will kind of point you in a direction.
Yeah, I think these more specific tests are very helpful, and I'm glad that some of these other tests are sort of being replaced. Like, for example, the NK function test, right? Where you send a massive amount of blood, which from a really young child, often that could be interfering with treatment. So I think there are some advances that are making things somewhat more specific and more reliable.
Yeah, and I'm glad you brought that up, because that was my next point, that it is listed in the diagnostic criteria, the HLH 2004, this NK cell cytotoxic function assay. At least when it comes to the diagnosis of HLH, we find it to be completely useless. And that's because if a child is sick for any reason, that assay comes back as abnormal. And in fact, in a small paper from our institution many years ago, my colleague, Dr. Rebecca Marsh, compared the utility, the specificity of the combination of CD107A and perforin flow cytometry assays compared to the cytotoxic NK cell assay, and found that the perforin and CD107A was far superior to the NK cell cytotoxicity assay. And the sad part is, just like you pointed out, you need large amounts of blood. But the worst is that it takes 5 days to set it up and run it. And at the end of that, you come up with a number that is not very useful. And we find our colleagues, especially in the hem-onc world, because it is listed as one of the criteria in the HLH 2004, and it's something a little more specific compared to the other non-specific markers of inflammation. People put a lot of stock into it, but in reality, it's not very useful. And instead, the markers of interferon gamma activity that we discussed a lot in the second episode in this conversation series, such as CXCL9, and also markers of T cell activation, are probably more important and valuable in getting us to the diagnosis. Now, the genetics is also, I'm hoping, just like you said, Dr. Lee, you really need a genetic assay to confirm it. But at the same time, as Dr. Canna mentioned, that unless the gene that is causing the disease is on the gene panel, you're going to miss it. And so even though our institution has an HLH gene panel, we actually don't use it because it's a very narrow panel. We prefer to get a more comprehensive panel, such as those that cover other immune deficiency diseases. And the main reason is that the discoveries of new genes has been so rapid that the panel developers at our institution have not been able to keep up. But I'm hoping that someday we will get a gene panel, perhaps even a whole exome, that will return faster than our flow cytometry assays. And we will be able to make a diagnosis much faster that way. Dr. Kenna, you were about to say something, I thought. Yep. Okay.
I think just to simplify that point, like currently the NK function test in an acutely ill patient, just don't send it.
Just don't send it.
None of our institutions send it. There's a recent redux of the HLH04 criteria where they removed it and they performed even better. So, there's the things that are in the criteria which are worth sending. There's some of these extra things which are going to help you diagnostically and help you with monitoring and interferon gamma activity. But the NK function is just not worth sending. It would be if it was normal. I think a normal test is helpful. It just never is in an acutely ill patient.
That's true.
And then, I agree with you on the next.
Yeah. All right. So let's get to then therapy now. We've made the diagnosis. Now that we understand that interferon gamma is one of the key players, and there are now newer drugs becoming available to target interferon gamma, how do we incorporate some of these newer agents, such as ruxolitinib, which is not a direct inhibitor of interferon gamma activity, but perhaps downstream, because the JAK-STAT pathway, it is utilized not just by interferon gamma, for that matter, many inflammatory cytokines rely on that. And so how does one then incorporate a drug like ruxolitinib, which is a JAK inhibitor? I know you all in the rheumatology world have been using it for much longer for other conditions, but in primary HLH, how do you currently use it, or how do you envision that it might become helpful in the future? Dr. Khanna, you want to start?
I'm going to defer to Dr. Lee.
Okay, then I'll tell you what, and after Dr. Lee, then I will tell you what I think of it. But Dr. Lee, what I want to hear from you first.
Yeah. So I think it has tremendous potential, right? Because we've been using this for juvenile arthritis for a few years now. It's FDA approved, and it has the advantage of blocking multiple cytokine pathways. And in the context of HLH, right, what we want is interferon gamma, right? That's the JAK1, JAK2 pathway, which was blocked by ruxolitinib specifically, and I think it also has the advantage of blocking other pathways also, right? And this is a cytokine storm, right? So it's not just interferon gamma. There we see type 1 interferon, we see some IL-6, we see other sort of JAK-mediated type of cytokines, chemokines, not chemokines, but cytokines and growth factors, for example, that could perpetuate the cycle of inflammation. So I think that's an advantage versus more specific targeting that I'm sure you'll get to. It is orally available, which could be an advantage in some patients. So I do think that it's a therapy that has lots of potential, and we're probably not have a lot of experience yet. But I think in the future, this is going to be a great option for many of these patients.
Yeah, when I was reviewing the data on this, there are lots and lots of case reports and small case series utilizing ruxolitinib, but in almost all of them, it was utilized in what was labeled as secondary HLH, when there was a cytokine storm in the context of something else. And then the number one actually driver in most of the case reports was EBV. And perhaps there it has more utility. In case of primary HLH, the clinical trial conducted by the North American Consortium for Histiocytosis, the acronym standing NACHO, is actually ongoing. And I think as much as I would hope that what we've just said is absolutely true, until we see the data, we have to be cautious that just because theoretically it makes sense, we don't just jump into it. And this becomes tricky because most of the patients who have primary HLH are young infants, and many of them are critically ill where we don't know if they will actually be able to absorb an oral medication. And some of the toxicities of ruxolitinib actually are, that we have seen, are liver inflammation and cytopenias. And many of these patients are already have. So it becomes a little tricky, but I remain hopeful that it will become one of the drugs that could be utilized in addition to the current standard of care, which is steroids and etoposide.
Right, and they well qualified my earlier statement also that we don't use it first line. Certainly, we still do the corticosteroids, and sometimes based on if we have the firm diagnosis of primary HLH, then they usually go with the established protocol. And if we don't have the established diagnosis yet, sometimes we consider IL-1 inhibitor, which we're more familiar with in the rheumatology world. That's the next scope before we think about JAK inhibitors.
Yeah, I think we've used it in a couple primary HLH patients by accident. In exactly the situation Dr. Lee was suggesting, where we didn't know what they had yet, and we're trying to stabilize them. And I think we use quite a bit of it and find it to be, titratable and useful. I think there are a couple challenges. One, children often need much higher doses than what you might anticipate based on what's in your, the dose that's used for adult, like rheumatoid arthritis or whatever, is oftentimes less than what you would give to a 2-year-old. So the doses we've given are often quite high. There's an interaction with azole antifungals, so you might accidentally be giving patients quite a lot if you just add on posaconazole for prophylaxis, which is the right thing to do, but you have to do a dose adjustment. And it's only oral, and so in the particularly ill patients, you may not want to be giving it enterally. But, I will say that, we've had a lot of positive experience with it, even in patients that ended up having primary HLH. But I'll also say that in those patients, it was not sort of a sufficient monotherapy, even at high doses.
Sure. And then, how about a little more specific therapy? So we know that interferon gamma, because it is one of the main drivers, one of the key cytokines, the monoclonal antibody emapalumab did undergo clinical trials and was approved by the FDA, at least in the United States, now almost 6 years ago. 2018, I think, was when the final approval came through. And the clinical trials and subsequent post-trial experience shows that it is quite effective. How do you, at least in our institution, because we see so much primary HLH, a lot of the patients on the clinical trial were enrolled from our institution, and the whole concept came from my colleague, Dr. Michael Jordan. So we are quicker to adapt or incorporate emapalumab to our treatment protocols for primary HLH. And now, of course, with the recent publications of its role and its utility in MAS, even there we have started utilizing it. How do you utilize emapalumab, and where do you see its role coming in primary and perhaps in other forms of HLH?
I'll say that we have been enthusiastic about the data in MAS of emapalumab, but have not really needed it. I mean, so if you're saying you have an MAS patient who you've given steroids and a good dose of anakinra or two, I can't, maybe a handful of patients in the last year or two that have needed more. And because it's not usually a plan for outpatient therapy, we often are putting those patients on ruxolitinib because we're trying to sort of get them ready to go home and get them off steroids. In primary HLH, I think that there's some discussion about, whether right now the approval is for refractory or recalcitrant or whatever, not first line for primary HLH. First line is still supposed to be dexamethasone etoposide. A recent review of the performance of etoposide suggested it was not nearly as toxic as I think a lot of us would think it is, and yet it's still a quite, leukodepleting chemotherapy.
Yep.
And so in our primary HLH patients, I would say that we have used emapalumab fairly early, and I think often through the course in towards transplant, because of some emerging sense that it's not just good for quelling the inflammation, but also maybe good for priming for a successful bone marrow transplant.
Absolutely right. It's almost like you were reading my mind as you were saying that, because recent data from my colleague, Dr. Bethany Verkamp, just looking at a small cohort of patients from our institution, showed that those who received emapalumab prior to transplant actually had much better outcomes, because one of the challenges in bone marrow transplant in primary HLH is the lack of adequate chimerism to control the disease. And those patients who had received emapalumab had a much higher incidence of retaining full chimerism compared to those who did not get emapalumab in their prior to transplant for controlling their HLH. In the last couple minutes, Dr. Lee, any insight from you on the use of emapalumab in primary HLH?
It's always a discussion, and when we go through the primary options in terms of steroids and then think about what to do next. In a few cases we have done in our institution, we've seen really good effects. I think what we have to balance is some of the potential side effects, right? We have the immunosuppression, where you have to do antibacterial, antifungal, antiviral coverage. That could be a challenge in some instances. And we have used it in some patients with secondary MAS in systemic JA also. And there, I think that has a value of thinking of this sort of HLH physiology as more of a transient process instead of a more sort of chronic recurrent process like you do with the primary phenomenon. And once we get the inflammation, get the cycle inflammation under control, right, that could sort of get you out of this cycle and for until something else happens, of course. But I do think it does have a lot of value for both primary HLH as well as secondary form.
Great. Well, with that, I think we will wrap up this third episode. Thank you so much, Dr. Khanna and Dr. Lee, and thank you all for watching and listening. And be sure to click on the landing page to claim your credit and also access supplemental slides and any other supplemental information that will be available.